Hello students. Hello everyone. Today I am going to discuss about the post-traumatic stress disorder. It is a psychiatric topic and myself is Munsha Khatun discussing about the post-traumatic stress disorder in this video. First we will be seeing how I am going to start this video. First I will be presenting you a case of this patient and then I will be discussing the whole topic in detail. Post-traumatic stress disorder. The person named Indu, age 29 years old, female, married, address is Aziznagar and by occupation she is a teacher. Comes with chief complaints of recurrent nightmares for the past 2 months. History of present illness. The patient was apparently asymptomatic 2 months back. Then she started having recurrent nightmares since 2 months. So means this person or this patient complains of the recurrent nightmares. And she has a history of road traffic accident 4 months ago. And she hospitalized for 2 weeks. She was unable to get the memories of accident out of her mind and can experience very vivid images of the events even during the day. Means that the accident which had happened to her 4 months ago, so the memories which are related to the accident she unable to take that off, and she has experiencing these vivid images of that accident even during the day. Mood swinging is there. Poor sleep and concentration. Sleep and concentration are poor. There is patient is unable to sleep and unable to concentrate on the things, and the patient has suicidal thoughts. She feels guilty about surviving the accident and states that it would have been better if she had died instead of her friend. In the past history, the patient has no past diseases such as hypertension, diabetes mellitus, or any chronic disease. Social circumstances. The patient typically avoids going alone, taking leave from job, avoids meeting new people, avoiding the situation that remind her of the accident, such as unable to travel in car. The patient complains that she was traveling in a car and she met with the accident 4 months ago. So everything which is associated with the accident, she is avoiding that. That is, if her accident takes place in Aziz Nagar, then she will be avoiding to go to the Aziz Nagar, because if she will be going at that particular place, then she will be reminding of that her accident had occurred, and then she will be suffering with the trauma. Okay, and she is also unable to travel in car because the accident had occur in the car. So she is avoiding such situations which gives her or remembers her about the accident which had happened to her. There is no family history of the mental illness. Alcohol and substance use. She is non-smoker, but she used to drink alcohol occasionally, but recently has started drinking every day. She says that she used to drink 1 bottle of wine a day. After the accident had happened, her alcohol usage increased. So that is it. And the personal history is she is married, the diet is mixed, the appetite is reduced, bowel and bladder habits are regular, addiction is alcoholic, and sleep is inadequate. On general physical examination, she is well oriented to time, place, and person. Pallor, icterus, clubbing, cyanosis, edema, lymphadenopathy are not noticed. Vitals, pulse is 82 per minute. Blood pressure is 124 per 76 mmHg. Respiratory rate is 14 per minute. Temperature is 36 degrees Celsius and JVP is not the standard. That is, jugular venous pulse is not the standard. So her vitals are normal. Everything is normal. On systemic examination, S1 and S2 is here. No murmur detected. No focal neurological deficit is seen. Bilateral air entry present. Normal breathing sound present. Mental state examination. So in psychiatry, we do the mental state examination. So on appearance, she makes good eye contact, anxious and has tremors in both the hands. Behavior and psychomotor function, psychomotor agitation, tremor, fidgety scene and hypervigilant. Hypervigilant means the patient will be worried, that is, the patient will be thinking that in her surroundings the patient is having some danger. So she will be thinking that in her surroundings the danger is present. So the patient will be hyper vigilant. Speech, she is reluctant to speak about the road traffic accident and starts shouting, become verbally aggressive when questioned about the accident. Means whenever we are questioning about the accident which had happened to her, she starts shouting and she don't want to talk about the accident which had happened, and she becomes verbally aggressive. There is no pressure of speech. Actually, the pressure of speech means the patient will be talking very rapidly. The patient will be talking, and this pressure of speech, we will be seeing in the mania patients. Okay, the mania patients are very excited, they are hyper excited. So in that patients who are with bipolar disorder, maniac patients, these patients are hyper excited, in that patients we will be seeing the pressure of speech in, but we will be not seeing the pressure of speech in PTSD, that is post traumatic stress disorder, because here the patient won't be talking at all. The patient will avoid to talk about the accident which had happened. But in mania or in bipolar disorder, the patient will be talking very rapidly. Okay, so this is how we are going to differentiate by pressure of speech between the PTSD and the mania or the bipolar disorder. The pressure of speech signifies that we are not dealing with the maniac, excitement or maniac. Behavior and psychomotor function. Psychomotor agitation, tremor, fidgety scene and hypervigilance, which are classical emotional symptoms of PTSD. So emotional symptoms of PTSD are psychomotor agitation, tremor, fidgety and hypervigilant. Mood and effects. Anxious, labile thought, worried and concerns about the danger, no delusion and hallucination. Cognition, decreased concentration and attention but intact. So concentration and attention are decreased but they are intact. Insight is present. The summary of this patient is a 29 years old female with a history of road traffic accident, presented with complaint of recurrent nightmares, mood swings and sleep disturbances after the road traffic accident. She avoids social situations and avoids to travel by car. She also feels guilty about friend being died instead of her. So on the summary, we provisionally diagnosis it as a PTSD because of the symptoms and also the duration of the symptoms. So in the next slide we will be discussing more in detail about PTSD. Okay, so the differential diagnosis of PTSD is angina, PTSD with depression, grief reaction, adjustment disorder. So how we can differentiate between PTSD, adjustment disorder and grief reaction is based on the three things or three criteria, that is type of stressor, onset of symptoms and type of symptoms. In PTSD, why it will be occurring, any life threatening accident, serious road accident or airplane crash or wars or rape cases, any life threatening accident can lead to the PTSD. But in adjustment disorder, the stress will be financial crisis or relationship issues. And in grief reaction, it is associated with the death of the loved one. And in PTSD, the onset of symptoms are within 6 months and it persists for a month. Whereas in adjustment disorder, it is within 3 months and persists for 6 months. In grief reaction, it is within 2 months and persists for 2 months. The type of symptoms in PTSD is repetitions of the thought. Like the patient will be having flashbacks, the patient will be having the nightmares of the accident which had happened to her. Emotional reactions, okay, that is the patient will be becoming fidgety, hypervigilance, okay, avoidance. In this, the patient will be avoiding to think about the accident which had happened, or to talk. The patient will be avoiding to talk about the accident. The patient will avoiding the situations where, or the places to visit where the accident had happened, okay. And the patient also avoid to travel in car if the accident is happened because of the car accident. Adjustment disorder, in this, the depression and anxiety symptoms you will be seeing, and in grief reaction we will be seeing depressive symptoms. So PTSD definition. PTSD is nothing but it is a response to stressful event which is of a life threatening nature, okay. And this PTSD is seen more commonly in young adults when compared to children, in females when compared to males. So the causes of PTSD is natural or man-made disorders, an accident such as a plane car crash or car crash or car accident, sexual assault like rape or molestation, kidnapping, traumatic childbirth, physical abuse, okay, being diagnosed with terminal illness, childhood abuse, coronavirus pandemic. So any life threatening condition can lead to PTSD. And now coming to the clinical classification of PTSD based on the time. If these symptoms, there are three symptoms, triad of symptoms in PTSD. First one is the repetitions of that thing which had happened in the form of flashbacks or nightmares. Second one, emotional symptoms are associated, such as the patient become hypervigilant, aggressive, okay, and avoidance of that things. So these three symptoms constitute and they lead to the PTSD. So if these symptoms last for a month, then it is acute stress. If the symptoms lasting for 6 months, then it is PTSD. If the symptoms lasting for more than 6 months, then it is a chronic PTSD. And in the complex PTSD, it is a chronic stress torturing for a long time, leading to the loss of his self-esteem, lost emotional warmth and connectivity. So this is complex PTSD. So this is the classification of PTSD. So the clinical features of PTSD is intrusion symptoms, avoidance, cognition and mood changes, and arousal and reactivity changes. So in intrusion symptoms, what happened? Involuntary and recurrent memories of that accident or incident will be coming in the patient's mind. Traumatic nightmares, flashbacks, okay. Avoidance, the patient will be avoiding the trauma related thoughts, the feelings, the people, the places, conversation, activities, anything which is related to the trauma, the patient will be avoiding that. Cognition and mood changes, can't recall the key features of event, negative beliefs about self or world. The patient will be having the negative feelings, okay. The patient will be having the fear, the anger, the guilt. In the clinical history, we see that the patient is having the guilt of losing her friend instead of her. She wants to die, then she feels guilty. So the patient will be having guilt or shame. Okay, diminished interest in activities such as the patient which normally doing like going to job or any work the patient is doing, now the patient will be avoiding that. So we seen in our case history that the patient is avoiding to go to job, okay. The patient feels alienated, inability to feel positive emotions, okay. Arousal and reactivity changes. The patient will become aggressive, irritable, self-destructive, hypervigilance, exaggerated statutory response. Exaggerated statutory response means the patient becomes surprised, and this is not a normal surprise. The patient is like hyper, okay, in this exaggeration. Problems with concentration, we discuss in the case history that the patient is unable to concentrate, poor concentration, poor sleep. So the patient having sleep problems and problems with concentration. So the in clinical features we see avoid thinking of the trauma, avoid talking of the trauma, easily frightened, negative mood, negative thinking, always on guard, cannot concentrate, flashbacks, avoiding activity, avoiding the places related to the accident which had happened, loss of interest, feeling guilty or shame, substance abuse. We see the patient taking increased intake of alcohol is increased after the accident had happened. So there is a substance abuse also. Sleeping difficulty because of the nightmares. Okay. So this is the symptoms of the PTSD. Now how we are going to diagnose the PTSD case. So based on the stressor, see, any life threatening stressor can lead to the PTSD. Any life threatening stressor, after that we have these symptoms, this kind of symptoms is if we will be seeing in the patients, and the duration of that is the duration. What is the duration of PTSD? That is, it is, we see here that the onset of symptoms are within 6 months and it is persist for a month. So if the duration of the symptoms are starting within 6 months of the accident has happened, in this we saw that the accident which had happened is 4 months back. So duration of the symptoms is within 6 months and lasting for a month. Okay, and functional significance. Okay, so on these things we are going to diagnose the PTSD. Now coming to the treatment. Immediate management is we should support the patient, encourage her to talk about the traumatic event which had happened, and to facilitate healthy emotional processing and coping. First line treatment is cognitive behavior therapy. It is a trauma focused psychological help in the form of cognitive behavior therapy. Cognitive behavior therapy, what we will be doing, we will be talking to the patients, okay, and the behavior and the thoughts which are there in the patients of related to that particular accident, the negative thoughts and the behavior, we are trying to change their thoughts or the behavior perspective into a positive one. Okay, so cognitive behavior therapy is that we are giving the psychological help to the patient. EMDR is eye movement and desensitization processing. This is a new technique. Okay, in the next video I will be showing in the next slide. Second line treatment is pharmacotherapy includes, we give SSRIs. SSRIs are selective serotonin reuptake inhibitors such as paroxetine or mirtazapine, which we can be used in primary care. Prazosin we give to reduce the nightmares, and propranolol is used to reduce the somatic arousal. So EMDR. In this, what we will be doing, we will be telling the patient to focus on the finger, and then we will be moving this finger. So when the patient will be focusing on the finger and when we will be moving, at that time we will be telling the patient to talk about the trauma. Okay, so when the patient will be talking about the trauma, so there will be desensitization of that thoughts or of that thing which is fit in our mind. So there will be desensitization of that thing, and then the information again reprocessed and put in back into the mind. So what we will be doing, that is, if the patient again and again telling about the trauma, okay, so there will be desensitization, that is the patient feeling pain towards that particular trauma will be less, will be getting reduced. So in that sense, the patient will be focusing on the finger and telling about the trauma, and there will be desensitization of the information and again the reprocessing of the information. So this will be helping the patient to come out of the stress, okay, and to lead a happy life. Okay, thank you.